Today my topic is lateral meniscus root tear in the ACL deficient knee, and I'm the fellow from Professor
You are
Fong, and this is a topic he's very interested. And as we know, the lateral meniscus root tear will be occur in the special area that will be very near the insertion of the lateral meniscus, and it has two different type, the radial tear or the avulsion type, especially we always seen this kind of type lesion in the chronic cases. And because of the anatomy, as a special anatomy character of the lateral meniscus root tear, it have two different insertion. One is MFL, the soft tissue insertion, and the other one is insertion to the tibial plateau. So if one of the insertion is complete, that will be not result in very significant meniscus extrusion. But if the both is a rupture or the body part of the meniscus is rupture, it will be result in a very significant meniscus extrusion. And we also find some special characters of this kind of lesion. This kind of lesion will always happen in young patient, and it's traumatic, always combined with ACL injury. And the incidence of the lateral meniscus injury is 7 to 12% in literature, and to our opinion, it's around 5% in our cases. And if we compare, and as we know, the lateral meniscus root tear will always combine with the ACL injury. If we compare the ACL injury and ACL normal patient, we can find the lateral meniscus root tear combined with ACL injury will have a almost 10 times higher than the ACL normal patient. And if we compare the medial and the lateral meniscus root lesion, it also have about 10 times higher in the ACL combined with the lateral meniscus root tear. So the question is why we need to pay attention to the lateral meniscus root tear. We have several studies to prove this, and we compare the patient after ACL injury with a high-grade pivot shift. That means the pivot shift is a 3+, and compare with the 2+ pivot shift and 1+ pivot shift. We found for the high-grade pivot shift, the patient will have a significantly higher injury of the lateral meniscus, and this will be around 80%. And for the 2+ is around 50%, and 1+ pivot shift is around less than 20%. But for the medial side, is almost no difference. So we think the lateral meniscus injury, especially for the root tear, is a risk factor to the high-grade pivot shift after ACL injury. And also we compare the 3+ pivot shift. The patient will have an incidence of lateral meniscus root tear around 70%. And for the 2+ and 1+, it will be less than 20%. So this is the risk factors for the high-grade pivot shift. And we also compare the ACL injury and combined with lateral meniscus injury patient. And we found the anterior translation of the tibia is significantly higher than the isolated ACL injury. There will be almost 6 millimeter compared 3 millimeter. And also the KT1000 measurement is different, 8 millimeter compared to 6.8 millimeter. So we think the lateral meniscus root tear will be a risk factor to the high-grade anterior translation of the lateral compartment after ACL injury. That means if a patient have a totally ACL rupture and combined with a lateral meniscus root tear, perhaps will result a high-grade pivot shift, or will have a high grade of anterior translation of the tibia. That is the reason why we need to pay attention to these special phenomena, the lateral meniscus root tear. And how about the treatment? I will show several cases. This is a male case and 21 years old, ACL rupture combined with lateral meniscus avulsion. It's a chronic patient. And the KT1000 is 21 compared to 9 millimeter and the 2 plus of pivot shift. And because the lateral meniscus root tear is a avulsion type, so we perform a pulse suture technique, and we drill a tunnel in 5 millimeter diameter and pass the suture with a suture hook to repair the lateral meniscus to rebuild the insertion to the tibial plateau. And after that, we check the pivot shift again. And if we lose the suture, there is a 2 plus of pivot shift. And we just tension the suture, and the pivot shift will decrease from 2 plus to 1 plus. And we think this will be this phenomenon will be proof that the lateral meniscus root repair can control the high-grade pivot shift. We performed the second look arthroscopy 1.5 years later, and we found the root area is completely healed to the tibial plateau. And also we can find the result in the preoperative and postoperative MRI. And this is another patient. He's 21 years old, female, and ACL rupture, lateral meniscus root tear. And KT1000 was 23 compared to 12 millimeter, and also 2 plus of pivot shift. And during the operation, we find the lateral meniscus root tear is a radial tear or a flap tear. So we perform the side-to-side repair with a suture hook, and we pass the suture and put 2 stitches to repair the rupture. And we also check the pivot shift after the repair. And also this is only repair the root tear and without ACL reconstruction. We can find the repair can decrease the pivot shift from 2 plus to 1 plus. And this is a patient, the preoperative MRI to show the totally rupture of the root area and is healed after the 2 years. And this is a video just after the repair. And then also we performed the second local arthroscopy. We can find here is the repair site is totally healed, is completely healed. And so if we find the lateral meniscus root tear, we will perform as this algorithm. And we will repair the root tear based on the different type. We can choose side-to-side suture, or we can choose the pull-out suture. Very important thing is we need to evaluate the pivot shift after the repair. If the pivot shift is decreased, we can go to the next step is ACL reconstruction. But if the repair cannot decrease the pivot shift, perhaps we need to perform the AL reconstruction to decrease the high-grade pivot shift. So we have different type. We have the different technique to repair this area. We can use side-to-side suture technique, or we can use a pull-out suture technique. And we also have the result, the clinical result, that will be a super higher healing rate of this area. For the avulsion patient, we perform the pulse suture technique. The complete healing plus the incomplete healing but stable patient will be more than 90%. Also, the side-to-side patient will get a similar result. Is more than 90% of patient can healed after the repair. And this clinical result is very similar to Professor An's paper that has published in 2010 in Arthroscopy Journal. And this area can have a very high rate of healing. So we think the lateral meniscus root tear is a very special phenomenon in the ACL injury that will have a risk factor for the high-grade pivot shift and the risk factor for the high-grade anterior translation of the tibia. Because this area will have a very good blood supply, so it have a high healing potential. So we need to try to repair this kind of lesion during the operation. And the very important thing is to evaluate the pivot shift after the repair. If the repair cannot decrease the pivot shift, I think the other procedure, such as the ALL reconstruction, is necessary. So that is my topic. Thank you for listening.
Greetings from England. So this talk really is going to be on some of the technical tips for ACL reconstruction using this new CONMED Infinity adjustable loop system. What I'd like to do in this presentation, we're going to go through some of the key components of the Infinity knee system, and then really try and keep this very much a sort of clinically based and technique based talk with some animations of how the devices are used, and then some actual surgical videos. Some are cadaveric, obviously, and trying to go through this. So what is this Infinity knee system? Essentially, this is a whole new comprehensive and reliable ligament reconstruction system that will cater then for every surgeon and to combine the techniques that others have used before to be able to work out and cover the needs that we have in reconstruction of the knee. Essentially, we've got guides, the devices for reaming, fixation devices, and accessories. And the illustrations here are just some of those items that are now available. And I'll just spend a few moments just going through those, with some of those to put it all together. The new tibial aimers, essentially different arms then to cover all the operations that we have, from PCL through to ACL, through the all-inside devices. So you have the elbow and the tip aimers and the footprint aimers to be able to achieve exactly what we want to. And they're really neat, quick connecting sleeve with this ratcheting sleeve that's easy to adapt, and the one-handed self-centering lock, which I'll show you on the videos. Reamers, these are quick coupling, no more fiddling around with the chucks and the drill heads, and these work with the quick coupling devices, different sizes, and the whole range is there from 5 to 30 millimeters and 0.5 millimeter increments. The femoral reamers, we still have the Sentinel low profile reamers, and the flexible reamers, and the Badger acorn reamers that have been around for a while. So this allows for accurate drilling on the femur. In addition, for the femur, we have this new femoral guide. For those that would like to have a guide to steer into the anatomic footprint area, then there are essentially two guides, one labeled 7 to 8 millimeters and one labeled 9 to 10 millimeters depending on the size of the tibia. It's clearly marked on the handle. And essentially these reference off the deep part of the notch and get the femoral tunnel into the anatomic position. For outside in reaming, then the retro reamer, and you'll see on the videos, it's a very simple deployment, just squeezing on the blue and to release it and squeezing on the triggers. And again, going to make that all inside easier. The Infinity adjustable loop button has this reversible tab, and this is the first of its kind to be able to do that. And by pulling on this reversible loop, you can then adjust it. There's a very easy trap device here, and then the lead suture to pull it through. It's the smallest button on the market. So this then really allows us to do that all inside. On top of that, the Infinity cradle to be able, the larger femoral tunnels, to be able to use that. And then at the tibial end, the Infinity adjustable free loop with this stitch through it, so it won't deploy, and that's a key feature that we'll show you as well. The whole principle of this adjustable loop is that once you put a graft through, then normally it would be of fixed length and you couldn't reverse it, but you can then pull back on the tab, and that pulls on one of the two strands. Then you can pull the rest of the graft down. So the end, the button here is then through the cortex, pull on the suture, and the Infinity button sits here. So then it can be reversed exactly where putting it where you want to go. In reality, then by pulling on that strand, you can see here how the Infinity button's held this part, and then it can be pulled back out again when you've marked the graft. The biodegradable screw, now using the matrix interference screw, and then the metal screw. This new screw is the Easy Start interference screw. Self-notching, self-tapping. This just goes straight in with no effort for the bone plugs. So if we look at some of the surgery options, and we've got different ways to fix ACLs, which you will know, and a whole multiple strand of the grafts, and we need our techniques to be able to work with all of those. Let me just run through some examples of that with the animations and the videos and try and put this together. This is ACL technique using the full tibial tunnel device. So we have our spade tip guide wire, using the guide, clearing out the old ACL and then putting the guide wire into the right place, referenced off the deep part of the notch. The benefit of this 3.5 millimeter spade tip means once it's through, you can hook back on the cortex and then going through the skin and using our drill. So you don't have to measure and you don't have to use a 4.5 drill to go through there. So it's all done in one, drilling the femoral tunnel and then using for the tibia, using the guides with the quick lock mechanism to set it at the right length. And it's on the ratchet then, as we saw. So this will be then making the tibial tunnel. And this is for the full tibial tunnel method of doing ACLs to then fix that into place. So then that's been drilled and that's done the tibial tunnel. You can see here the bullseye guide actually puts us right onto the footprint area. And you can see the markings here when that's pulled back on the cortex, then the spade tip, and this one happens to be 30. So once the tunnels are drilled, then we're pulling the infinity button up into place. We're pulling on the blue and white sutures, and the button goes through, locks onto the outer side just because you pull back on it and it holds there. And then by tension on the back end of the graft, by pulling on the blue tab part of the infinity loop, it then deploys. And then if you need to reverse it or pull it back out, if it's over tight, then that's easy to do as well. So here is an example. This is taking the graft. So the infinity loop comes on this cardboard mount. You just clip it into your holder. I'm going to put 4-strand graft here. So we've got our semitendinosus and gracilis. We'll have a clip onto both of those. Instead of having 4 sutures now, we just need 2 sutures to whip stitch the ends, and then they can be then held to one side. Now I would choose to use 20 millimeters in the femoral tunnel so we can make a mark at 20 millimeters on the graft to see that when it goes into the knee. And then when we've measured the whole femoral length, we know that, say it's 35 or 40, then we'll make a mark on the suture part at the length. So this one is 40. So you make a mark at that point, and that should be where the button, the infinity button, will flip on the cortex. We take it off the cardboard holder, which has been neatly made to make passage of the graft easy. And there's the graft. So we'll wrap it in our vancomycin wrap and put that to one side. That's being prepared while the tunnels are being prepared. So here is a case then, removing the old ACL to identify the exact footprint, using an RF probe to go between mid and AM bundle position, identifying the proximal border of articular cartilage. That's our reference point. This is where we're going to make our femoral tunnel. In this case, it's not using the femoral bullseye guide. And then a microfracture pick to make our starting point before bringing in the spade tip drill. And that's brought in, then the knee bent up to full flexion to make sure we get a good length of cortex. And there's the guide wire now going through. So that's an easy guide. And then using the drill to drill up and make that femoral tunnel. We want 20 millimeters ready for the graft. So we can stop at that point and put our lead suture through, removing any further debris. And that suture is then ready for pulling down the tibia. Tibial guide to make our tibial tunnel ready for the graft to pass through. So that tibial tunnel, the guide wire can emerge. I personally prefer a tip guide, and then over drilling that area to pull the suture then down through the tibial, and that's ready to pass the graft up through. So here is the graft. You've taken it out of our kidney dish, pass it through the loop. In this case, I'm using a tensioner device, so that's not essential, just to be a preference, and then pulling the lead suture up through the tunnels. To pull it up through the knee, we're using the blue and white suture. That keeps the button in line. From inside, then, we need to see how the sutures go up, and you'll just see it on the top there. There goes the button. Then the purple line will appear, and that should be at the entrance level of the tunnel before pulling in the graft. Now, then winding the graft, you can see it on the main picture, and then the graft goes into place, removing the reversible tab, and then we can fix it at the tibial end. Pablo pointed this bit out. His tip here, when shortening the loop and pulling it in, he likes it that he does it himself. So he's pulling at the top end and then holding the suture back. So the same person has got that tension. And then this adjustable loop works without moving the button off the femur. This is the new tibial adjustable guide. You can see how easy it is to use and then to lock and then to drill the tibial tunnel. The entrance of this is nicely rounded, so the guide wire is the small parts of the operation. It goes so nicely, easy to put the wire in. The constant reamers, this quick connect device to be able to easily drill the tibia. You can see that coming through here before bringing the suture loops back down that tibia, removing any debris from that area. Once those suture loops are then through, you can see that, and then the graft can be pulled up into the knee. So moving on now to the patellar tendon. Here's the patellar tendon animation going into the knee with the guide wire through the anteromedial portal. And this is the new Easy Start metal screw. And it really is, as it says, Easy Start. You can see how the threads just bite into that area. So no more tapping, no more hammering, no more worry about will the screw strip the graft, because it bites easily and goes in. Just to show you an example of that, this is 18 months ago, putting in, there's the bone plug going in, our purple mark on the graft, and then the screw. Obviously, I can't demonstrate how easy it is to go in because it just starts there, but then it's none of that hammering to get the screw to start or tapping that area. So these I really like. These are a big improvement on fixation of the bone plugs. Right, last bit, we'll move on to the all-inside ACL system. So the key bit here, we have the free loop, right? And this green suture here stops it from locking. So it will stay at that same length once it's pulled down into the tibia, and you can't then shorten it by doing that until the green loop is out. And then these really neat little tibial buttons that then hold onto the tibia from the little peg bit and easy to drop over onto the suture and tie it. So this is a way of preparing that graft. We've got our 28 centimeter graft, so we're going to fold it into 4 to make a single strand. We've laid out the infinity loop with the button, and then we've got the free loop at the lower end. These can be held in the graft preparation board and then sutured. And so there's different ways to suture it, to put a circumferential suture as well to hold it. We've got a 7 centimeter graft then, preparing both the femoral end and the tibial tunnels for this to dock into place. Now here is the reamer, and that black line is important because we need that clearance when inside the tunnel. So taking the new guide arm goes onto the femoral footprint. Once that black line is through, and what you need to see when you see this is how easy it is to actually deploy by squeezing on the blue part here that flips the retroreamer. And these come in the different sizes to draw back and make that femoral tunnel. We'll tap in place this oversleeve through the cortex. That keeps it in place. Slide the rubber band down, so then we'll know exactly how far it's pulled back to make, again, our 20 millimeter tunnel. We're going to dock it full depth into the femur, the graft, and then make a tunnel in the tibia for longer than the graft to be able to adjust it. So this is using our loop to go through the shuttle, then bring that out through the skin, and then we can shuttle our loop back through to be able to pull into the graft. And the same then for the tibial aspect as well. The same way with the retroreamer to draw down into the tibia. So here's a cadaveric case. Through the skin, you can see there's the reamer there, and just tapping that into place. Now there's the size of it in the notch. Just click on the blue and it just turns the 90 degrees. You see the black line in that place, drawing back for the femoral tunnel the required depth. And that then is a reliable system to do it. You can deploy it forwards to then disengage it and pull that back out through the. There's our suture shuttle, wire tip to be able to bring out through the skin. And pulling our suture loop back up again, ready to pass the graft. The tibial tunnel, then same thing, the guide again, with the all-inside fitting, basically to be able to use the retroreamer to put that into place and then prepare the tunnel in the exact anatomical point that we want. So then in the insertion of the graft, similar to before, using the infinity loop on the femoral end, length is right, and you can adjust the length of that to make it longer, easier to getting in through the skin. And then once you pulled on the blue and white to get it through, then you're pulling on the tensioning end, holding tensioning back on the graft. Once that's docked in place, then pulling in the tibial end. And you can see at the bottom end there's a small gap there because that's going to be used for the tensioning bit. And this is where the reversible loop comes into play. There's the tibial button, just to drop into that aspect. Then remove this green locking suture here so the locking mechanism can slide, get the tension right, and throw on some knots. So we're just showing that here. This is the femoral end going through, and there you can see the infinity button, pulling that into place, and then pulling on the tension. There's a little blue tag on the end. Got to keep tension on the back bit here. You can see that on the right-hand side to pull this into our mark. We know that's gone in exactly 20 millimeters. Then pass that through the loop on the tibia. Be able to pull that down into the tibia. We've still got our reversible loop hanging in there, which can be removed later. And then pulling the tibial end to snug back down into the tibia. And what we then want to see is the tibial button, how that just fits in there. It's easy enough to hold. It's not too small. There's no passing of sutures through the loop. And the little peg on the base holds it onto the tibia. You can either use fingers or a small clip, and it seems to stay there nicely. And to hang it this way, obviously, so that it stays in there rather than pushing it from the inferior surface upwards. And because it's this adjustable loop, it then docks down nicely onto the tibia, and it's still worth just tying knots over the top of it. So in summary, what we've been through is the techniques. The principle here is to maintain the basis of this anatomic surgery, to get the graft exactly where we want to, the easiest method to do it, and to get it in the right place. That's still a key principle. Shown multiple techniques, and we've got multiple graft options. We haven't really covered the use of allografts, but essentially that is the same way as using a through tibial tunnel technique or an all-inside technique. We've seen the accurate instrumentation that gets us in the right place with the guides that can be used. So you've got the multiple range of guides to be able to use it. And some new techniques, innovative techniques of being able to fix exactly where we want to go. And in particular then with the support behind us, this is what's allowed us to take arthroscopic surgery to that next level to be able to treat our patients. So with that, I do acknowledge our group of the surgeon teams. We know many of these people, and it's been a big team effort combined with the engineers from ConMed. And I really appreciate the opportunity to be able to go through these techniques for you and show you the ideas. Thank you.
Thank you so much, Mr. Spalding. So we had some questions come in from the field here, and I'll start asking them. So number one, what are your indications for an all-inside reconstruction versus an anteromedial approach, if you have any indications to specify either?
Yeah, I think my preference, but because maybe I've been around a bit longer, is to stick through the tibial, transtibial tunnel, full tibial tunnel method rather than the all-inside. I can see the advantages of that, and it's been very neat with PCLs. I've been doing that with my colleagues in Coventry. There's a big advantage there, but for the ACLs, my personal preference, so I don't have any objection to doing the all inside, but I tend to stick with the full tibial tunnel approach and then interference screw.
Thank you. So next question, how do you address rotational instability in a multi-ligament repair? Are you considering any form of lateral extraarticular tenodesis?
Yes, that's a very good question, and I think we've learned a lot about the extraarticular procedures in recent years. I've been part of the stability study, finally trying to understand the true benefit in the active young person that adding in primary lateral tenodesis into ACL reconstruction for the at-risk patient. That study was 16 to 25, but it highlights the reduction in failure rate. So for the younger person getting back to a fast pivoting sport, then definitely for an ACL, I would add in lateral tenodesis. And then in the multi-ligament, that's about understanding exactly what the instability pattern is, using stress x-rays, clinical examination to understand which part of the lateral or the medial side needs to be reconstructed. And then using the adjustable loop system, especially for posterolateral corner, is a very neat technique, way of using just one hamstring tendon to be able to reconstruct posterolateral corner and not have to use a longer allograft. So that's those options by using the infinity button and the other aspects can really help as well.
So what are your thoughts on the adaptation of soft tissue quad tendon in today's graft options?
Yeah, that's another good question. I think that's very much a growing field, and we then need to make sure we've got good harvesting equipment for quad tendon and then the fixation. So if we've still got the same devices to drill the tunnels, we can have a good short graft, sutured, and then that's where this will work, fixing over a button and using the adjustable loop system. I think the quad tendon results are good. There was a concern over the data from the Danish registry, but I think that's been analyzed in more depth, that it is not so much of a concern. And I'm really impressed by the papers and the results that are coming out on using quad tendon, so I would use it a lot for revision situations. Less in the primary, my workhorse is still hamstring tendons and then patella tendon for some high-level athletes and kneeling activities. So quad tendon, yes, that's definitely on the up, and the system is there for it.
Perfect, thank you. The next question that we have, kind of in reference to the tibial button, but have you seen or had any experience with post-op pain using a tibial button?
No, I haven't. I think we have to accept that annoyance from that button may well help, and if people have not got much covering on that area. It's usually, because it's off to one side from the tibial tubercle, I think it's reasonably well tolerated. Still need to tie the knots. Maybe the tip of making sure the periosteum is removed around that area so it's not sitting on too much bulky tissue. It's bound to happen that there will be some people that don't like it, but as a fixation method, less chance of that being a problem than having a screw in that area, or the staples. It's going to be smaller than that. But I think those are inevitable things that are going to happen with it. And once we warn people about these fine-tuning moments that might be needed in the future, and that's fine.
Thank you. So a question has come in more specific to the Infinity system here and the design team specifically. What inspired the innovation of some of these new products, and how do they differentiate from other products on the market?
Where do I start? So I think the beauty was CONMED wanted to look at what was new, and many of us have sort of ideas in the back of our mind of things, and that's partly born then from what's annoying and what doesn't work so well. So you can sit down and you trust your colleague then to talk about the items that are not good and this phrase unmet need, or what the issues are and what doesn't work so well. And from that comes an idea that is just such a fiddle, passing a button through the femur, drilling this and drilling that, and surely we can have a better way of doing it. And then from that comes the ideas. The beauty of this new Infinity Loop, which I really like, yes, it's adjustable, but it's so easy to pull through. And it's got other applications as well then that are going to be low profile for how it actually will deploy and not leave a large knot. I really like the Easy Start screw, the metal screw for the bone plugs, because that's been a real hassle getting screws to start sometimes. And with that thread tip that was born out of there is a problem. It's hard to do this. There are other items out there that seem to be easier to start. So that's something that I really like as well. And then bizarrely, that little button on the tibia, I hated dropping some of the competitor ones where you're passing the sutures through. So you say, there's a problem, we need something that's better, fits well, just the right size to clumsy fingers, and then will actually work. So yeah, it's really nice working with the team that can take an idea and make it work.
Perfect, thank you so much.
My topic today would be on ACL reconstruction with lateral extra-articular tenodesis. And we all know that anterior cruciate ligament injuries are extremely common. Some of these are high-velocity injuries, resulting in significant disruption of kinematics of the knee. The anterior cruciate predominantly leads to abnormal anteroposterior translation of the tibia on the femur. But more importantly, damage to the secondary restraints leads to varying degrees of rotatory instability, the commonest of which, of course, is the pivot shift sign. The pivot shift is not just a clinical sign, but it is a disabling symptom which is experienced by patients who have an ACL deficient knee. During my 3 decades of experience of ACL, I have seen 3 major changes. In the late 80s, starting from, of course, 67, when Lemaitre introduced the lateral tenodesis, in the initial years, we started doing the lateral tenodesis for addressing the ACL deficient knee, because the concept then was that the knee was like a rotating box, and we felt that the lateral structures could be tightened and the pivot shift avoided. Of course, this did not help with the anterior translation of the tibia. So the results were not great. Starting from the early 90s till almost about 5 years ago, we believed that arthroscopy was the magic wand for the knee and everything could be done arthroscopically. And we were swayed by this minimally invasive technique of ACL reconstruction. We tinkered with ACL reconstruction, changing to the transportal technique and even to the double bundle, only to find that in spite of a perfectly executed ACL reconstruction, there were almost 30% of our patients who continued to exhibit instability, which would not allow them to return to their normal functional levels. And hence, we were looking for answers to this, and we realized that we had developed a tunnel vision of the arthroscopist. We had forgotten about the periphery of the knee, and we were looking only at the contents of the envelope and ignoring the periphery. And therefore, today what we see is a well balance of a surgical technique where we look at the intra as well as the extra articular structures and reinforce these whenever necessary. There are 2 schools, if you look at the anterolateral side especially. One school which believes firmly that the anterolateral complex with the distal Kaplan fibers plays a major role in stabilization on the anterolateral side. And there is another school which believes that there is a distinct ligament called the anterolateral ligament, and this ligament needs to be reconstructed for restoration of stability in case of an anterolateral rotatory instability of the knee. Now, there have been various consensus groups, expert groups, editorial comments, biomechanical studies, but ultimately we find that the orthopedic surgeon is confused as to which technique should be used in which case. Today, to confuse this further, we have from Smigleski what we call the condylar strap, where you can see that it is not just a single band of tissue, but a canopy of structure which covers the entire anterolateral ligament, which needs to be restored to restore stability for a person who has an explosive pivot. The basic goal of all these lateral extra-articular reconstructions or augmentations is basically to provide support on the lateral side well away from the central pivot of the knee, and this is what each of these procedures is trying to achieve. In our practice, we prefer to have the LET over the ALL for a couple of reasons. Basically, you do not require any graft for the LET. Closing the gap in the iliotibial band itself leads to tightening of the lateral capsule that is stretched very often because of repeated pivoting of the knee. And you have fewer tunnels and implants, so it is very economic for patients who cannot afford to have any expensive procedures. All patients do not need an LET in the presence of an ACL deficient knee. Decision making is done on clinical evaluation, imaging, and arthroscopic assessment. The Drawers test, one of the oldest tests that has been described for ligament deficient knees, in fact described by Segond himself way back in the late 80s, and its variation should be used to assess the knee properly clinically besides the pivot shift. We also rely on radiological science, not just the MRIs, but plain X-rays as well, which may show you a Segond's sign. If patients have significant anterolateral bone edema in the acute stage, or they have a root tear of the lateral meniscus in the chronic stage, and a significant lateral impact on the lateral femoral condyle, then these are some of the helpful signs to decide on the lateral extra-articular tenodesis. We also feel that arthroscopic assessment of the knee before doing an LET is also important, And as you can see here, there's significant opening on the anterolateral side and a capacious capsule. And in this case, after doing an ACL reconstruction, if we find that this is still open at time 0, we would go ahead and do a lateral extraarticular tenodesis. So these are some of our indications: a grade 2 or a grade 3 pivot, especially in a young individual, especially in a varus alignment of the knee, somebody who wants to return to pivoting sports, in those with a significant LFC impact or damage or stretching out of the lateral restraints, and in the setting of a revision ACL reconstruction. We initially started with the classical Macintosh procedure, where the IT band was routed through the intermuscular septum, but we found that the exposure required for this was quite extensive, and therefore we shifted to the modified Macintosh, where you took an IT band strip and passed it under the LCL. This was a soft tissue restraint which did not constrain the lateral compartment excessively, and this is what we use when patients have grade 1 pivot or maybe a grade 2 pivot and low demand individuals. So this is how the Macintosh is done. We do the Lemire procedure and the modified Lemire in patients who have a grade 3 pivot and who are basically high demand individuals. And in this case, as can be seen in the cadaveric study, the strip of IT band taken from the middle third is passed below the LCL and fixed at a point which is about 5 millimeters proximal and posterior to the lateral epicondyle. Here is a live surgery which we have demonstrated. The IT band strip is taken, kept attached at Gerdy's tubercle. Whip stitches are taken all along. High tensile suture material is used so that when you pass a screw, it does not lacerate the graft. We then identify a point which is about 5 millimeters proximal and posterior to the lateral epicondyle. The direction of this wire is proximal and a little bit anterior so that there is no confluence with your tunnel on the femoral side of the ACL. This is the graft which is passed under the LCL. And this is then fixed with the knee in about 30 degrees of flexion and in neutral rotation. We have found that if the fixation is done in external rotation with the leg in external rotation, you can have excessive lateral compartment compression. So this is an arthroscopic view showing after doing an ACL, there was significant opening on the lateral side. As one can see, you can easily, there is a drive-through sign which is positive. And after doing the LET, one can see that the lateral compartment has been completely obliterated. So various studies have shown that there is a significant reduction of pivot shift after using an additional LET. The stability study, as mentioned by Tim Spalding, also has shown that there is a reduction on the ACL graft stress by almost 43%. And therefore, we feel that the LET is an excellent substitute for to complement the ACL reconstruction in selected cases. There are a few technical issues that one can have during an LET, and one should be very precise while doing surgery. The tunnel, femoral tunnel for the ACL, as well as the tunnel drilled for the LET could be very close. And so if you are not certain, it is better not to pass the ACL graft before drilling the tunnel for the LET. And once you have confirmed that there is no coalition, then the grafts can be passed. One of the problems that we initially saw was increased patellofemoral compression. This was a lady who was an avid trekker, and every time she did any kind of kneeling or she did any kind of trekking, she developed this patellar edema. There was another patient who had significant wearing out of the lateral facet of the patella, and hence you need to be careful as so that you do not over tighten or over close the IT band interval. We also need to realize that from Houston's talk, there could be a diametrically opposite lesion. So one must not just purely focus on the anterolateral aspect of the knee. attention should always be given also to the posteromedial corner. As we can see, in almost 14% of our patients, there is a ramp lesion which may be associated with a pivot shift, and that needs to be addressed. Finally, we should remember Houston's words of wisdom. He said that I believe that the so-called anterior cruciate deficient or sufficient knee is in reality an insufficiency on our part to be able to recognize the associated injuries to capsular ligaments and the menisci, and therefore we should not be swayed by this so-called ACL deficient knee. So in summary, I think we should all, as clinicians and surgeons, look at concomitant extraarticular lesions, which very often are present with the ACL. Procedures should be customized according to the patient profile, and it should be the LET should be used with due caution in valgoid knees, and one should not over constrain hyperlax knees. Thank you very much.
So essentially, we'll be talking about how we use the Zone 2 cannula system for looking at doing all inside meniscus, for doing inside out meniscus repairs. What is important and essential here is to look and use special needles with 2O polyester suture or 2O ultra high strength suture, and these are loaded on flexible nitinol needles. We've traditionally used the various straight cannula systems. However, they do have a problem because they will allow you to sort of go in only one direction, and this has sort of limited your capacity to use the inside out system to a small area of the meniscal repairable tissue. What we want to do is to expand the indications or the area or the zone for which we can use the inside out system. And for that very purpose, I think the Zone 2 specific cannulas become extremely useful. These Zone 2 specific cannulas come in a variety of curved angles, and these are not only curved in one plane, but they are also contoured so that you can use them to very effectively maneuver around the curvature of the femoral condyles to reach the menisci at various locations. What's important is that with the help of these cannulas, which are used through varying portals, you can reach almost all areas of the meniscus. The yellow arrow that I have demonstrated shows probably what you can do with a straight cannula, but with the help of these Zone 2 specific cannulas, you can reach more and more areas of the meniscus which you can repair very conveniently. So that's the amount of repair you can do. As with most of the inside out repair conditions, you definitely want to create a safety incisions if you're planning to go more posterior, and these can be made very effectively by utilizing skin incisions which are based posterior to the MCL or the LCL. We open up the fascia, and then you may use a simple bent spoon, or you can use a special meniscus retractor to pass it in between the capsule anteriorly and the head of the gastrocnemius posteriorly in this particular fashion, and then your needles can be very easily and effectively passed so that they deflect over this particular spoon or your meniscus cannula, and thereby you can prevent damage to any of the neurovascular structures. So what we demonstrate here is a patient who has a large horizontal cleavage tear. It extends right from posterior to way anterior, and in this scenario, you want to then start using the specific zone cannulas. So we start now at the middle zone using the middle cannula. Since this is a large horizontal cleavage tear in someone who is 26 years old, you want to preserve meniscus tissue as much as possible. So you will be passing cannulas in the middle zone using the middle side specific cannula. Once you've passed the sutures in the middle zone, you want to now move ahead to the anterior zone, and you will start using the anterior cannulas, which will allow you to reach way far to the anterior third. This becomes very important and very critical because when you do an inside out technique, I think you have the great opportunity to pass multiple sutures. When we move to the posterior zone, this is where your safety incision becomes really important. And now you've started passing sutures in the posterior third or the extreme posterior third of the meniscus. And the beauty, as one can demonstrate here, is that how lovely this contour of the cannula easily negotiates the femoral condyle as well as helps you reach the meniscus and allows you for a perfect trajectory as well. All of these steps are very critical and important because you do not want to damage the articular cartilage in any form when you are doing such repairs. When you finished repairing this meniscus, you want to ensure and understand that you've had a good repair, a repair which you feel is mechanically strong, because the only thing that we can easily alter is to provide a meniscus repair which has been reduced anatomically. We provide biology by doing all sorts of biological augmentation techniques. And last but not the least, we want good compressive sutures, which will then complete our repair. So here's what this repaired large horizontal cleavage meniscus tear that has been repaired looks like. We've put multiple sutures and we've closed the mouth, thereby giving this patient a good rim of meniscal tissue, which hopefully should help him carry on with his normal life. How do these techniques compare? Well, if you look at a systematic review, you can see that though the inside out will have a slightly higher risk of nerve irritation, you will find that the meniscus, the all inside technique probably has a higher risk of implant breakage. Again, what we see here is that another updated systematic review shows that there is not much of difference if you look at all the various failure and the complication rate between the two techniques. Again, another study which was published out of the Mayo Clinic group showed that the failure rates were almost equal for both techniques, with a slightly higher risk of minor complications in the inside out technique. Another systematic review with a meta-analysis, especially with patients who were younger than 30 years with a follow-up which was more than 2 years, shows probably slightly higher failure rates with the all inside and more complication rates with the all inside. But the complication rates with the all inside are usually more often than not quite minor ones, which really does not give much of a problem. So I think to conclude, what is important to understand is that the zone 2 specific cannulas help you in achieving good meniscus repair. It is a safe method. It is an effective and a reproducible technique as well. Definitely, it is a cheaper method, especially when we are looking at large meniscal tears, and the results and the outcomes are comparable to that of the other techniques. Thank you very much for this opportunity.
Today I want to talk how I recognize the femoral tunnel in the ACL reconstruction, especially in the renal preserving technique. This paper, 2010, they reviewed 122 consecutive failed ACL reconstruction patients, and they found in 88% with the non-anatomic graft placement, especially in the femoral tunnel. You can see the 61 in the wrong tunnel. So we know that anatomic reconstruction is crucial, and the optimal femoral tunnel is more important. But the question is, where is the anatomic point, and how to recognize it? We have to answer these two questions, then we can make a perfect tunnel in the femoral tunnel. So let's look at where is the anatomic point. According to a study by Sasaki in 2012, they demonstrate the ACL insertion can be divided to the direct insertion and the indirect insertion. The direct insertion is a stronger attachment because there is a traditional zone, and the indirect insertion is the relatively weaker attachment. So another study proved it. They cut the indirect insertion, and they found compared to the ACL intact, there's no increase in the anterior tibial translation. So the interray insertion is not crucial for the anterior tibial translation. In the further study, they separate the footprint to several parts, and they found in the area of G and H, they provided 60 to 84% of total resistance to anterior tibial translation. So according to the anatomic and the biomechanics study, we should place our tunnel over the high and the deep area. It's just over the intercanthal ridge. But we know the ACL is a ribbon-like, it's a flat ligament like this. But we always create a tunnel in a round shape. And when we place the graft inside the tunnel, when we tension the graft usually eccentrically displaced anterior and distally. So if we were just concerned the anatomic and the biomechanical, the graft should be placed over here. But if we consider clinically the round tunnel with the eccentrical displacement of the graft, we have to move our tunnel more deep and more high, like this yellow circle. So I think this tunnel, this position is the more optimal position for the femur tunnel. So after we know where the case is, the second question is how to recognize the femur tunnel. There are some, many methods can help us to recognize it, including the reference landmark. You can use the ridge remnant tissue, and you can use the femoral offset guide ruler, and some surgeons use the Sion, the cross-drain method to target the point, and of course some surgeons like use the navigation as well. However, the Sion and navigation is time-consuming and increase some complications. So the landmark is still the gold standard, especially for the arthroscopist. We always like to recognize the landmark to help us to recognize the femur tunnel. The ridge, intercanthal ridge, is the most popular landmark and can be identified by arthroscope. However, if you want to recognize the ridge, you have to remove all the remnant tissue on the lateral wall. And sometimes if you remove the soft tissue too aggressively, it will disturb the ridge, then you cannot find it. So for me, since about 7 years ago, I like to use the posterior landmark to help me to recognize the femur tunnel. There are two landmarks I used. One is the posterior femur cortex, and the other is the end of the cartilage of femur condyle. Why I use these two landmarks? As we know, the intercanthal ridge is the extension from the posterior femur cortex, and the end of cartilage, we know, is the upper limit of your tunnel. It means if we place our tunnel over this limit, you have a great chance to place your tunnel on the roof. We don't like to place our tunnel on the roof. So if we look at these two extension line and the cross area, I think there is the optimal position of your tunnel. So I use my video to show you my reference point. In this case, we can puppet the ridge over there because this is a relatively easy case. You can see there is not much remnant left in the lateral wall. So in this case, it's very easy to identify the landmark. So I use this one to show you first. And when we puppet the ridge, then we can use the electric cautery to clean the soft tissue behind the ridge because there is the ACL insertion point. I always like to use the 70-degree scope because this 70-degree scope can help me to have a better visualization of the posterior part of the lateral wall. And I use the electric cautery to make a mark of the lateral wall. This mark is the point, I suppose, the femur tunnel. So after I make a mark on the lateral wall, then I can introduce my scope from the anterior medial portal to the posterior lateral compartment. And with the 70-degree scope, we can easily to visualize the posterior femur condyle, posterior femur cortex, and the end of the cartilage, like a photo right side. So, and I can see my mark over there, and you also can see the roof. So we can image the line from posterior femur cortex and the end of cartilage. And I think the mark is in the optimal position. So after the confirmation of the position, I move back my scope to anterior lateral portal. So you can see we still can visualize the mark over there because we use the 70-degree scope. And I know the tunnel position and the direction. Then I use the femur offset guide introduced from the anterior medial portal to target the point. The femur offset guide is a good instrument because it can help me to hold my guide pin to target the point. And it also can be control the direction of the tunnel. Sometimes we have to change the tunnel because of the length. And of course, it can prevent the posterior cortex broken. So it's very helpful instrument. So after reading the tunnel, sometimes I can go back to the posterior compartment to confirm the position of the tunnel. And by the 70-degree scope, you can confirm your posterior cortex and your tunnel is intact. There's no broken of your posterior cortex. And you can look very clear the femoral cortex and the end of cartilage. And then we can find the position of the tunnel is in the optimal point, like this. So to follow up the MRI, we can see the graft is a good position, and the X-ray and also in the cedar tunnel is good. In this case, because she suffered a traffic accident, so my colleague arranged a CT scan, so I have a chance to look at the femoral tunnel is in the optimal position, and no impingement in the extension status. So this is the easy case, but sometimes we make the patient with remnant left. Like this patient, the PL bundle is still intact, and there is much remnant over there. So in this patient, I don't want to sacrifice, don't remove the remnant tissue. I just want to perform the AM bundle reconstruction and preserve the PL bundle. But in this kind of patient, it's very difficult to use the landmark on the lateral wall to recognize your femoral condyle because there's too much soft tissue over there. So it's a good case to use the posterior landmark. So again, use the electric cautery to clean the lateral wall of the AM bundle and to make a mark on the lateral wall. This mark is, I suppose, my femoral tunnel. Then you introduce the scope to the posterior lateral compartment. You can see in this kind of patient, the space is very small. But if we use the 70-degree scope, we still can have a better visualization of the posterior femoral cortex, and you can look at the end of the cartilage like this, and we can look at the mark I make by the electric cautery. So if we draw a line, we can see the mark is in the optimal position for femoral tunnel. So again, we use the femoral offset guide to target the mark on the lateral wall and to make a drill and to then make a femoral tunnel. So sometimes in the random preserving cases, I usually should check again my entry point before I ring the tunnel because I want to preserve as much as remnant as possible. So before I ring, I want to check again if my point is correct or not. So in this case, we preserve the PL bundle as much as possible and just to perform the AM bundle reconstruction. So after that, the postoperative X-ray, you can see the tunnel is in the optimal position. And we can preserve the PL bundle well. So this is my technique, my favorite reference to recognize my femoral tunnel. So in my summary, I think accurate femoral tunnel placement is crucial for successful anatomic reconstruction. And too familiar with the landmarks and the instrument can be helpful in creating the optimal femoral tunnel. I think The posterior femoral cortex and the end of cartilage is a reliable and reproducible landmark for recognizing optimal femoral tunnel with the help of 70 degrees. This is my presentation, and thanks for your attention.
My topic today is ACL reconstruction in pediatric patients. We have special interest about the pediatric adolescent knee because they have more functional instability comparing to the adult patients. So our children is very different in terms of structural, neuromuscular, biomechanical, and hormonal because they are growing. So for boys for until 16 years average, for girls 14 years, they are growing. They have very knee resting until growth complete. So we need to have careful individual analysis for this specific, very valuable for our future dream. So the functional instability and the physical plate is a very important consideration when doing in treating ACL injuries. So now, until our society is developing, so we have a very good interest about the psychological health for our children because the ACL injury makes the reducing sports activities. This is a breakdown of friendship and teamwork and unable to participate in sports activities. This memory is very painful for the children until the whole life. So this is our duty to return back to sports activities, to making friendship and teamwork in these very valuable ages. So until COVID-19, we should have a specific consideration of our school ages to the sports activity must go on. Because although our society has a lockdown, we need to specific consideration of the adolescents and the children to move on to maintain the psychological activities and the physical activities. So this is the epidemiology of Korea. So the incidence of the ACL reconstruction is increasing now, and especially for the 10 to 20 years. So there is a gradual increasing. So absolutely male predominant for the ACL in Korean societies, comparing to Europe, especially for United Kingdom and America. So our total incidence is almost similar to the United Kingdom. So 29.1 per 100,000 people, comparing to the America. So we have 1/3 of incidence. So America got more injury. That because they are participating more highly grade sports activities in the adolescent ages. So increasing aging group is 20 and under 20s. So maybe we need to prepare for the future to treatment for the pediatric ages. What about the treatment option? So this is generally believed that wait until face is stable or face is closure. But as I mentioned before, the functional instability is increasing and the cross plate is not so dangerous, and the pediatric psychological problem is another issue. So for the children's human right, so we need to do something to prevent these kinds of damages. Non-operative treatment makes residual instability and increasing secondary injury. This will make some at 33.7 times more instability than the operating group, and the risk of meniscal injury and condylar injury is more than 12 times. So this is not safe. This is not a good choice for these growing children. So current consensus for the ACL tear in pediatric patients is early surgical intervention and the restoring stability of the knee. So we have several options of treatment option. So fissure sparing technique, it has an advantage of avoid the disruption of open physis and the decreasing chance of growth disturbance, but it has disadvantage of only partial improvement wear and stress on the graft, especially on this femur. This is very sharp angle of graft bending angle and the increasing risk of re-rupture. So this is generally recommended of girls less than 11, boys less than 12. Is recommended to fissure sparing ACL reconstruction because they have significant growth remaining. And another option is a transfissure. That means fissures respecting technique. It has advantages with simple technique with a natural tension pattern, but disadvantage is the increasing risk of growth disturbance and angular deformities. So fissure respecting technique means no bone plug or hardware through the physis, and the use of fixation away from the physis, for example, the endo button or X button to avoid the potential risk of premature growth plate closure. This is a result of the systematic review. So on the summary, so there is no difference between the fissure and the fissure sparing in terms of leg length discrepancy, angular deformity, and the re-rupture rate. So maybe we can use both the fissure and fissure sparing in the adolescent group, but special consideration of not harmful for this growth plate. So this is our protocol. So we use the research stage. Less than stage 2, we introduced the physis sparing technique with outside in with flip cutter. And the research stage more than 3, we introduced the transtibial technique with the soft tissue graft. This is the case of 11 years of male with research stage 0. So we introduced the flip cutter with the CM, and then for the safety of the physis, we can introduce the outside-in technique. This is the CT, and this is the X-ray to sparing physis. So this is the result. And we have a special consideration after the surgery. This is our result. So re-rupture rate of our past 700 patients, re-rupture rate is 2.4% of adults. However, this is the result of the children, adolescent, 14.2%, significantly higher than the adults. And what about the contralateral rupture? So only 6 in the adult, 1%, but 8.6% for the adolescent group. So maybe the rupture rate of the graft and the contralateral rupture is significantly higher than the adult group. This is the problem. So why? So this is because of the functional instability. So we need to introduce a specialized injury prevention program for this higher risk group of adolescents. So return to play at 9 months is is safe for the adults, but still dangerous for the adolescents. So the return to play, especially for high-level activities until 2 years, is significantly safer than the early return to sports. This is our research for the muscle strength. This is the 2 years result. So contralateral knee still shows significantly muscle weakness comparing to the normal group without any ACL injury. This is one of the cause of contralateral rupture. This is the reconstructed group, the reconstructed knee, significantly lower than normal knee. So we need to special consideration to restore muscle strength and the functional status in both limb without although there is not injured limb, this we think this limb also have some significant weakness and sensory dysfunction. This is our meta analysis of the injury prevention. So odds ratio of 0.4, this is effective especially for the plyometric and the strengthening balance, especially for the adolescent group is efficient for the injury prevention mechanism. So what is how can we introduce this injury prevention? So we introduced modified Mandelbaum method with warm-up, stretching, strengthening, plyometric, agility, these kinds of injury prevention for 20 minutes before start the high level activities. So this will significantly reduce the risk factor. So the problem is that the children, adolescents, so easily return back to sports. So comparing to the others, after 8 months of ACL reconstructions, 50% of adolescents return back to sports. However, for the beam symmetry index, only 29% has returned to the functional level. So too early return back to sports will increase the re-rupture and the secondary injury. So this is our message. So injury prevention at least 1 year is safe for the adolescent group. So this is the survey from the active Herodicus Society in AOSSM. So they have enough experience of treatment experience. So gross arrest is 11%, but currently reported nothing. So tibial side they want to transfeasial, and the femoral side 50% transfeasial, 10% the physical sparing, 32% still they maintain over the top, escape the physical injury. Graft choice, 60% autogenous hamstring, 20% the patellabone tendon. So this is our ongoing research for ALL healing and clinical outcome in ACL reconstructions comparing to the adolescent group and the adult group. So our conclusion until now is adolescent group has low rate of healing of ALL and then increase the functional instability comparing to the adult group. So maybe special treatment of AL injury could be considerable procedure, especially in adolescent patients. In summary, ACL injury in pediatric patients have different characteristics compared to adults. More active and enthusiastic treatment should be considered for both the physical and the mental care. The result of physical sparing and the transphysical results are generally acceptable. Relatively higher incidence of rupture and contralateral injuries should be considered. Specific postoperative management is needed to prevent complication for this age group. Thank you very much.